Good evening. I want to start by thanking the organizing committee for inviting me to give a talk. I have to apologize that I'm not there in person, that I'm recording this, and I'd be happy to take questions via email. What I've been asked to speak today is on nutritional issues in peritoneal dialysis patients. I want to start by saying, just reminding people that over the years, a large number of studies have been done that have compared the survival of patients that are treated with peritoneal dialysis, compared that to hemodialysis. You can find, if you have a certain opinion, if you think one modality is better than the other, you can probably find a study to support that. Hundreds of such studies have been done. But I think the preponderance of evidence is that compared to the mid-1990s, the survival of patients that are starting treatment with PD has gotten better. That at least in this study that we did some years ago, if you follow up patients through 5 years, the survival in people with hemodialysis and with PD is essentially the same. And I would just argue that we need to put this behind us. In the United States, that has resulted in changes in public policy that have increased the financial incentives for using PD starting in 2011. If the survival is the same and PD is a modality for the United States that is cheaper to the payer, there is value in promoting that. And as you can see, prior to 2009, 2010, the number of people that were doing PD in the United States had been flat. But with those new incentives, the number of patients actually has now almost doubled. These numbers go only through 2018, that was 3 years ago, and there were almost 60,000 people. I think now there are more than 60,000 people that are doing peritoneal dialysis in the United States. It's almost 111% increase from its lowest use in 2004. And the increase has not plateaued. Not only is the absolute number of people going up, the proportion of people that are treated with peritoneal dialysis is continuing to increase in the United States. One of the concerns people have had is that if more people do PD, maybe the outcomes may not be as good. But what has happened over time with the implementation of the rule, actually the outcomes have improved. I'll start in this visual abstract from left to right. As you can see, over time, the risk of transferred in-center hemodialysis has actually gone down. Discontinuing dialysis is somewhat higher, but not much, and the risk for death is more or less the same. So overall, the more you use a therapy, the better you are in using the therapy, and better are the outcomes. So it is not surprising that as people get more experience in using PD, the outcomes are getting better. I'm not going to spend time on this entire thing. What I showed you has been the effect of change in policy thus far. Since then, in 2019, the Advancing American Kidney Health Initiative was initiated. It has a large number of important goals, but an important goal is that 80% of new patients should be starting with home dialysis or transplant. Now, 80% is a very high goal. It's like, the word I use is it's Trumpian. It is like the biggest and the best and the most. I think to expect that there will be 80% new patients that are starting with home dialysis or transplant, I think is an unrealistic expectation. There are presently 12% of people that are doing dialysis at home in the United States, and the expectation is that by 2030, there could be about 20% of people doing dialysis at home. And there is actually further financial incentives that the government has put behind that, effectively in the form of a randomized controlled trial. That there are what they call as the entire country is divided into hospital referral regions. I live in the Seattle hospital referral region. There are 306 of them, and a third of them have been assigned to what they call as the ETC model, where the more you do transplant, the more you have people dialyzing at home, the more money you're paid, versus a usual care group where it's customary payment. The allocation of the referral regions actually is randomized. And so it will be the first randomized controlled trial being run at a national level by the government of the United States, testing that if you offer more financial incentives, can you have people do the right thing? It's unfortunate that there's a need for financial incentives for doing the right thing, be as it may. I think the bottom line here is that I anticipate further growth in the use of PD in the United States. I wouldn't be surprised that by 2030, there are over 100,000 people doing PD in the United States. Now, let me just get to then what I've been asked to talk about is nutritional considerations in patients on PD. And I've used the template from the KDOQI guidelines on nutrition in kidney disease for this presentation. And there are three components of diet, at least in the way they've organized it and in the way people in the field of nutrition think about it. The first is macronutrients, and we talk about protein and energy. Then there are micronutrients. These are all vitamins, and then include minerals like selenium and zinc. And then there are electrolytes that we are very used to thinking about in nephrology. There is the acid load, the calcium, the phosphate, the potassium, and the sodium. Now, the acid load actually is linked to protein intake because most of the net acid that is generated from the protein content. The higher the amount of protein that you take, greater is the amount of acid that is generated on a daily basis. So those are the three components. When you think about diet, one has to think about macronutrients, micronutrients, and electrolytes. Before I move on, I'm not going to cover each one of these. I don't have enough time to cover each of these. I will cover some important components of that. I want to start off by first saying that the strength of evidence for practice guidelines is not very strong. So if you look at all of the guidelines for kidney disease overall in these KDOQI guidelines, there are 72 statements. And of these 72 statements, 85% of them are rather weak. That means 45% of them are opinion-based and 40% are grade 2 statements. That means the evidence is not very strong. If you specifically look at the guidelines that would be applicable to people in PD, there are 54 statements. Maybe the evidence is a little better, but even then, it is 80% of people, 80% of those statements are either a grade 2 evidence or based upon opinion. I'm not being critical of it. It's where the field is. But the important thing, I'll get to that. There are only two things that have a level 1 evidence. The first is that the first one applies to people on hemodialysis, saying that serum albumin may be used as a predictor of hospitalization and mortality, with lower levels associated with higher mortality. And then there is a statement that says that essentially, don't worry about high homocysteine levels. Like if you don't check homocysteine levels, if you have high homocysteine levels, treating it doesn't matter. So these are actually, none of them provide guidance on what to do to take care of PD patients. The implication of me starting off by saying that is that there's lots of room for clinical judgment. So there is no hard and fast guidance in what needs to be done. These are some general comments from experts, but there is a lot of room to make judgment one patient at a time. So let's move on to macronutrient intake. In patients on peritoneal dialysis, it's recommended that the protein intake be between 1 and 1.2 grams per kilo per day. So in somebody that's 70 kilos, it should be between 70 and 90 grams of protein in a day. And for recommended energy intake, it should be between 25 and 35 kilocalories per kilo per day. The one thing I would like to remind you is that in patients on peritoneal dialysis, the total energy intake is the energy intake from diet but also energy intake from dialysate. Whether it is glucose-based dialysate or amino acid-based dialysate or icodextrin-based dialysate. Up to a third or more is absorbed, and with glucose, actually up to 2/3 or more is absorbed during a dwell, and then it can contribute to the total energy intake for an individual. This is just giving an illustrative example. There are two important determinants of the amount of glucose that is absorbed with peritoneal dialysis. First is the concentration of glucose or dextrose. This is 1.5% dextrose, 2.5, 4.25% dextrose. So higher the concentration of dextrose that you use, greater will be the amount of glucose that is absorbed. And then what will depend upon is the peritoneal solute transfer rate, whether it is a low, average, or high, so that higher the solute transfer rate, greater will be the absorption. So these are rough back of the envelope calculations. These are not actual estimates, but just for the sake of argument, just so that you get a sense of what that it is that the total energy intake in a day from dialysate can vary between 240 to 1160 kilocalories a day. In a 70 kilo person, that is between 3.4 to 16.6 kilocalories per kilo per day. I'll get to it. There's a lot of focus on, oh my goodness, that's so much sugar that's being absorbed, and that must be bad for the heart. Maybe, I'm not so sure about that. But I think an important concept when thinking about how much food people take, if there is energy intake is protein sparing. So that if you are able to take a higher energy intake, then for you to maintain nitrogen balance, it'd be all right if you were taking a little less protein. And so patients may need less protein if they get higher energy. And that is an important, again, a way of individualizing the prescription. I'm saying you have to get 70 to 90 grams of protein, but if somebody's taking, say, a high carbohydrate diet, or if there's glucose absorption, maybe they can get by with lower. The next important thing with regards to the macronutrient intake is the diagnosis of protein energy wasting. These are the guidelines from the International Society for Renal Nutrition and Metabolism that has outlined these four areas, like four categories of tests that one can use for the diagnosis of protein energy wasting. It could be abnormal serum biochemistry, reduced body mass, reduced muscle mass, unintentionally low dietary intake. As per the guidelines, at least one test in 3 of these 4 categories should be abnormal to make a diagnosis of protein energy wasting. So if you have a low serum albumin, you have a low body mass index, and you have, say, for example, a low protein intake, that's enough to diagnose protein energy wasting. I just want to highlight this issue about serum albumin because the cutoff in these guidelines is for a serum albumin of less than 3.8 gram per deciliter. One of the important things to understand is that in people on PD, the serum albumin is lower. There is protein that is lost with PD. There is 6 to 8 grams of protein that is lost every day with PD. So that in people with serum albumin, in people that are on PD, the serum albumin is lower. These lighter color bars are the serum proportion of people with serum albumin in a certain category with PD, and the darker ones are with hemo. And as you can see, this is a very large population of patients. There's a study that we did some years ago that in people that are doing hemodialysis, 55% of them had a serum albumin of less than 3.8, but it was a higher proportion of people in PD. It was 63% of patients that had a lower serum albumin. It's all right to know, we know that serum albumin is an important predictor of mortality, but the important thing is that for any given level of serum albumin, the risk for death in patients on PD is lower. And if 3.8 is the optimal cutoff is the optimal mortality cutoff that is used to diagnose protein energy wasting, the effective level in patients in PD is something like 3.6. This is like, again, a back of the envelope calculations. I just am emphasizing the fact that the serum albumin level is lower in people on PD. Do not I am not certain that the threshold of 3.8 that the International Society of Renal Nutrition and Metabolism has selected, that same threshold of 3.8 should be applied to people for PD. So it is lower in patients treated with PD. Be careful in using that same cutoff for diagnosing protein energy wasting in patients treated with PD. And the most important thing is, do not transfer patients from PD to HD simply because the serum albumin is low. It is important to put serum albumin in the larger context for the individual. And as long as they're otherwise doing well, just because their serum albumin is low should not be a reason to transfer them to hemodialysis. What about treatment of protein energy wasting? The principles of treatment of protein energy wasting are the same, no matter what stage of kidney disease or what dialysis modality they have. For all of these, again, the evidence is not very strong, but nevertheless, the principles are the same. The first step is nutritional counseling with the goal of increasing dietary protein and or energy intake. And if people are not going to be able to increase the amount of food that they're taking by themselves, then you can prescribe them oral nutritional supplements. One of the challenges, of course, is that adherence with oral nutritional supplements is challenging because in part it is because they're expensive. In part, the reason why people are not eating enough is because they don't feel good enough to eat. So overall adherence is low. Nevertheless, in the small studies that have been done, there is some evidence for benefit, and it is an important next strategy. If you look at the KDOQI guidelines, the next step is, if oral nutritional supplements are not enough, is for people to do tube feeds. Now, I have done that maybe in 2 patients in between 1,000, 2,000 patients I've treated collectively on dialysis. I've done that in 2 patients, and both of these patients were those that had diabetic gastroparesis, that I could not have them keep their food down with them taking it orally, so ended up putting up a tube feed in them. It's always challenging to have tube feeds to put a feeding tube, like I'm talking of a gastrostomy tube, and not a tube like a Ryle's tube through the nose. It's challenging because of the risk of peritonitis. And if you place a gastrostomy tube, it's probably prudent to give them antifungal prophylaxis and interrupt PD for a week or 2. But it is something that can be done. There is no evidence to recommend intraperitoneal amino acids. There have been studies. There was a time when there was interest in using intraperitoneal amino acids. There have been clinical trials that have been done to look at their benefit with regards to the nutritional status, and the studies thus far have shown no benefit. The next question is, the next thing that I want to address that is the issue of metabolic acidosis. Don't forget metabolic acidosis. And I'm just going to start. I'm going to show you 3 studies that have looked at this. This was a metabolic balance study that we did years ago, in which we admitted patients to a metabolic ward and have them get a fixed diet, had 2 periods. The first, we randomized them to a pH of 7.37 or a pH of 7.44. And as you can see, except for this one patient, this patient 6, in every other patient, every time we went from a pH of 7.37 to a pH of 7.44, the nitrogen balance was more positive. And of course, this is, both those pH levels are normal. One is the lower end of normal, one is the higher end of normal. So the higher end of normal is better than the lower end of normal. This is a clinical trial that was done in the UK. And this was a time when there were 2 different preparations of PD solutions that were available. There was a low lactate and a high lactate, a 35 and a 40 milliequivalents per liter. Now the 35 milliequivalents per lactate solution is no longer available. It's only the 40 milliequivalents per liter of lactate. But remember, lactate is the buffer in PD. Lactate is absorbed, it's metabolized to bicarbonate, and the bicarbonate that is coming from the lactate is what corrects the metabolic acidosis with PD. And so in people that were using a 40 milliequivalents per liter of lactate, they ended up having a higher serum bicarbonate. The bicarbonate level was actually 27 compared to 23. Now, this is a study done 25 years ago. But importantly, it resulted in an improvement in nutritional status. This is showing in people that were getting the high lactate solution, where the bicarbonate was more like 28, they had a greater increase in the mid-arm circumference. They also had greater weight, lower hospitalization rate, and fewer hospital days. There's another study that was done in China, that was done in Hong Kong by Zito. They randomized 60 patients on PD. As long as the bicarbonate was less than 24, they gave them oral sodium bicarbonate or placebo, and the treatment resulted in an increase in subjective global assessment and NPNA. And this is actually the number of hospital days, that the duration of hospitalization actually was lower in people that got bicarbonate. So I've shown you 3 different studies in patients on PD, looking at different ways of correcting metabolic acidosis. The metabolic balance study that we did used oral bicarbonate. The second study by Stein used PD solutions with 2 different lactate concentrations. And this one study used oral sodium bicarbonate. And in each of them, the higher bicarbonate group had a bicarbonate of about 27 to 28. 26 to 28 is where the number was, that resulted in a clinical benefit. And so KDOQI guideline recommend that the target bicarbonate should be between 24 and 26 milliequivalents per liter. So kind of wrapping up then the treatment of protein energy wasting, there is an important need for nutritional counseling. There is a role for nutritional supplements. There's tube feeds, but don't forget metabolic acidosis. I just want to switch gears, because one of the things that is often said is that in people that are doing PD may gain a lot more weight because the glucose is being absorbed. And that is nothing more than a myth that just never will die. And I'm going to show you 3 studies that have looked at the change in body weight in people starting treatment with hemo versus PD. This is the first study published now 20 years ago from the Netherlands. And these this is the open one is hemodialysis, the closed ones is PD. The important thing is not the difference between the two, but that these curves are parallel. That once they start treatment with dialysis, there's actually no difference in the change in weight between people starting hemo versus PD. This is a study that we did in the United States. This is tens of thousands of people. And then our expectation, as you can see, there were like almost 37,000 people on PD, on hemo, and 700 people on PD. My expectation was we'll show again, like the previous study, that there was no difference in weight gain. But actually in this, the probability of significant weight gain was greater with hemo than with PD. So that it was quite the converse. The myth is people on PD gain more weight, but here actually the people on hemo gained more weight. And this is the 3rd study that was done in Australia. And again, the important thing is not these trajectories. I just want to point out that these triangles is PD, these closed circles above is hemo. The important thing is that the trajectory of weight gain is the same between hemo and PD. And let me orient you to here, like, this is something that that you can relate to with your clinical experience. When we start somebody on dialysis, their volume overloaded, you remove the extra fluid, they lose weight, then their appetite gets better, and then they gain weight. And as you can see, there is no difference in trajectory in weight between patients treated with hemo or PD. So I really don't think that there's a problem with weight gain. I think that problem has been overstated, and one should be very careful in attributing that to PD. I want to close by talking about potassium. As nephrologists, we're often focused on problems with higher potassium levels. We know from general medicine that low potassium is bad and high potassium is bad. And this is like one of the studies we did years ago now, showing the same thing in people in PD, that the low potassium is bad and the high potassium is bad. But the problem in patients in PD more often is the low potassium. As you can see, this is again, the open bars are PD, the dark bars are hemo. As you can see, patients in PD are much more likely to have a serum potassium of less than 4. As you can see, up to 10% of patients would have a serum potassium of less than 3.5 in patients on PD. So it's the low potassium that is far more important for people on PD than hemo. And there are multiple reasons for that. People say, hey, because the dialysate potassium in PD is 0, that they're having a lot of potassium losses, but loss with dialysate is not enough to explain hypokalemia. Yes, loss is important, but it has to be coupled also with inadequate dietary intake, because one needs to take 60 to 80 milliequivalents of potassium in a day. And if you're not taking that amount of potassium, and then you're losing the potassium in the dialysate, then you get hypokalemic. There are two other things that have to be considered. The first is that we are giving glucose in the dialysate. The glucose in the dialysate is absorbed. That triggers the release of insulin. And insulin then leads to potassium being pushed into the cells. Also, diuretics that are used often in people in PD can further cause hypokalemia. So kind of all put together. So there is the dialysate losses, the inadequate intake, the insulin that is pushing the potassium into the cells, and use of diuretics all collectively. And then if you're treating constipation with laxatives, that also increases potassium loss and can result all in hypokalemia. So this is an important nutritional issue in people on PD, that for most patients undergoing PD, dietary restriction on potassium intake is not necessary. This allows for a liberal intake of fruits and vegetables, and it can also allow for safe use of ACE ARBs. All right, so in these last 27 minutes or so, what I've tried to say is that use of PD is quite different in different countries. In the United States, use of PD is increasing. Nutritional management of PD patients is very important, but there is very little evidence that allows room for clinical judgment to make decisions. Be careful with serum albumin. It will be lower in those treated with PD. And it's just because the albumin is low is not a reason to transfer somebody from PD to hemo, as long as they're doing well otherwise. In people that have protein energy wasting, increasing oral intake is the preferred approach. Correct metabolic acidosis and liberalize potassium intake. Thank you for your attention.